So our next speaker is going to be Professor Markus Tiemann from the Institute for Hematopathology in Hamburg, Germany. Professor Tiemann has worked for 16 years within the Department of Hematopathology, where he has been the vice director. In 2004, he founded the Private Institute for Hematopathology in Hamburg. Together with his colleagues, the Institute provides a range of services that includes histology, cytomorphology, immunohistochemistry, and immunophenotyping, as well as comprehensive next-generation sequencing-based molecular diagnostics and bioinformatics analysis of complex biomarkers. He uses innovative technologies such as digital pathology and artificial intelligence to strengthen the diagnostic capabilities in order to best support the hematopathologist and oncologist with the therapy decisions of their patients. Professor Tiemann main focus is lymphoid neoplasms and leukemia, and he's also very active in the studies of myeloproliferative diseases and in myelodysplastic syndromes. Let's welcome Dr. Markus Tiemann to the podium.
Hello, good afternoon or good morning, depending on your location. Today we'll speak about next generation analysis in chronic lymphatic leukemia and other malignancies, and I will show you some user experience with this LymphoTrack assay. Just diving into the clinical differences in chronic lymphatic leukemia, we have first to take a look on the guidelines. Recommended analysis are cytogenetic demonstration of deletion of chromosome 17p, and of course IGHV gene mutation analysis, and then molecular genetic analysis of TP53. And in the end, and this is optional and depends on your local resources, you can analyze a panel of markers by NGS. And the clinical meaning of this is shown here. You see the low-risk group with a somatic hypermutation with a very good clinical cause, and then one intermediate group, and then the high-risk group. And in this publication, it was a group of patients with a 70p deletion. And in a more recent paper, you can see how this changes according to the therapy which is used in these patients. You see here this both the yellow and the dark blue curve, they show nearly the same clinical cause. These are hypermutated and unmutated IGHV gene groups, and with a conventional therapy, a very historical treatment with chlorambucil, you see there is a clear-cut difference, and which is more important, how longer you observe the patients. So this IGHV gene mutation is predictive for which therapy you have to use, and other markers as BCRI or BCL2I show no advantages in patients with mutated IGHV status. But with these BTK inhibitors, this is a very important clinical decision dependent on your results. What we are looking for this region, the VH region of the immunoglobulin protein, only in the heavy chain, and this clonality status can be measured with several assays, but the assays we are speaking today and we have the best experience with is the LymphoTrack assay. The workflow is very easy. First, you have to do DNA extraction and then polymerase chain reaction, and after that, you have to purify the amplicons using magnet bead systems, and then we have amplicon quantification by RT qPCR. Then this is followed by multiplexing amplicons, and then we do a sequencing using the Illumina MySeq platform, because this is very useful for these short sequences and also for paraffin embedded tissue, and in the end data evaluation. And you see this time frame is relatively short, 2 days for these first steps, and then sequencing needs 2.5 days, and in the end data evaluation only 1/2 hour. This is very fast, and you can spare a lot of hands-on time, especially on well-paid molecular biologists. How does this look? This is very easy and very good to understand. Here on this side, in this table, you see the sequence of the different clones. Here's the number of clones. They are ranked to their size, and then the length of the clone. Then here the V gene used, the J gene used, and the percentage of total reads, and then the cumulative clone. Cumulative means you add the clones on the same length on this bar, and then you have here the mutation status, and here there's information about whether this clone is productive or non-productive. So on one view, you can be very fast and to understand very easy what is the matter in this case of CLL. Now we start with real cases, not only with theory. We have here a 62-year-old man, and he has a leukocytosis or lymphocytosis since several years, and the clinical diagnosis was chronic lymphatic leukemia of B-cell type, and now they did want to understand which therapy could be the best one. Do we need transplantation, or can we have more conservative therapy, or do we have to use the more modern BTK inhibitors? And then the analysis shows this one row here. The main clone is shown here in green, and there are several other clones also present. And the main clone, the length is written here. Here is the rearrangement described, and this is the length of the CDR3 region. You can use this later for MRD analysis. There's no stereotype subset, so this is a good sign, and the mutation rate is 4.64%, and that means in the end favorable prognosis. Very fast, very efficient, and very reproducible. The next case I presented for you, this is a 79-year-old male patient, also clinical information CLL since several months, and we already know the molecular data that the cytogenetic analysis, this showed trisomy 12, and there had been no additional mutations. So this should be at least an intermediate risk or a good risk, but we have to look for the mutational status, and to our surprise, there could be identified 2 separate clones, and this with our method we used before, with the Sanger sequencing method, this is always complicated, but here we could identify the 2 different clones, one with 6.8% mutation rate, the other with 8.8 mutation rate, and this is both the same direction. Both rearrangement show somatic hypermutation, and this is very easy to analyze in parallel, and this is of course a strong advantage over traditional Sanger methods, in my opinion and in my experience. The next step then is amplicon-based NGS system. You can use different customer-based PCR panels, and then use this MySeq platform, and in the end you have this reference sequence and look what you have found there. you can analyze larger gene panels, and that's a great advantage, long gene sections in parallel. And the improved detection limit is 3 up to 5%, maybe from 2% upwards. These clones show clinical relevance. Which genes do we use in our current panel? The genes are listed here, and most of them are very important parts of very important pathways, signaling pathways of B cells, especially Notch1 is of high importance. I will show you MyD88 is more seen in Morbus Waldenström, but also present in CLL. And these three markers are very intensive, correlated to therapy answer. And then, of course, the NF-kappa B pathway, you already know, is very, very direct link to proliferation of the B cells. And the clinical meaning is shown here in the paper of Rossi. It's from 2012. You see wild-type patients with a very good cause and mutation, mutated TP53. Disruptive mutation of TP53 is much more worse, and also BRCA3 shows a disruptive mutation. These had all been patients treated with immune chemotherapy, so including CD20 antibodies. And also TP53 wild type and TP53 functional mutations, you see they're much more worse. And here it's shown in combination, cytogenetics and molecular genetics. You see TP53 mutation only, TP53 mutation and deletion, they are the most worse. Then we should expect that both alleles are mutated, and TP53 cannot show any function anymore. Okay, so just several examples for this, and then we try to compare how many we can see with a Sanger sequencing of TP53 and what is to be seen in NGS. And you can find here mutation incidence, no mutation detected in 49%, and mutations detected in 51%. And this shows you here distribution, which mutations had been found: TP53 mutations, BRCA3, ATM, Notch1 mutations, and SF3B1 mutations. This is not a bias of study patients. This is real world data. So patients, most of them had been outpatients from private practice, and you see you can find much more. And if you look for the allelic frequency, the limit of detection of Sanger methods is maybe around about 15% of the alleles, and with the allele frequency lower than 20%, that had been 46% of the cases, and we analyzed 234 patients. So you would miss a significant part of the mutations of TP53, at least, using normal Sanger sequencing. And the genetic testing, what we do now is classical cytogenetics, then IGHV gene mutation analysis, as you have seen, and TP53 analysis. Mostly this is included in such a panel, and this gives the best results for the therapy decisions our clinical colleagues can do. But not only in CLL, IGHV HV gene analysis is makes sense, but also in other entities. Here is another example, a 68 years old female patient. The clinical diagnosis or the histological diagnosis was mantle cell lymphoma. That looks very similar to CLL with very mature cells. And with the lymph tract assay, you could show here very good clonal rearrangements. And then you see some more subclones. And these are analyzed here. And you could make the same analysis and with and not using more time as in CLL. So it works also in mantle cell lymphoma, marginal zone lymphoma, splenic marginal zone lymphoma, hairy cell leukemia. You can use this for nearly every B cell entity. Sometimes in follicular lymphoma, it's a little bit more difficult because you can have out-of-frame rearrangements. And another example here for the mantle cell mutations. This is a non-mutated example of mantle cell lymphoma, and the clinical meaning, however, it's not yet clear-cut defined. We have to find out whether in the era of ibrutinib and other BTK inhibitors, this will play a role in therapy of mantle cell lymphoma or marginal cell lymphoma compared to CLL. And then there is a completely other part of lymphotract possibilities. It's not only useful for IGHV, it's also useful for T-cell receptor gene rearrangement analysis. Our main question in diagnostic procedure is the question between initial mycosis fungoides, to differentiate between initial mycosis fungoides and parapsoriasis en plaque. This is more or less an inflammatory disease, self-limiting, and this is of course a peripheral T-cell lymphoma, and you have to do some therapy with these patients. And the histology won't help you so much to decide this because it's nearly the same pattern, and it's very hard to decide, is this an initial mycosis fungoides or not? Is this in parapsoriasis? And with the help of the lymphotract, you can have this. We use normally T-cell receptor gamma chain gene locus analysis and T-cell receptor beta chain locus. Both gives more deep insight in the rearrangement process. And here, if you look at the literature of the biomid markers, that's a quite complicated procedure, and it's really a challenging field. But with a lymphotract, it's much more easier. And if you compare this with a gene scan assay, I think the accuracy is much more higher. This is again example from a living patient. So 41-year-old female patient, and the clinical information was mycosis fungoides. And now the question arises, is this leukemic form of mycosis fungoides? She had some strange cells with indented nuclei in the peripheral blood, and we would like to know, is this clonal or not? And here you see many polyclonal T cells, and then you see this, and can this be really a clone, or is this an artifact? How to clarify this? With lymphotract, you see lots of clones here. Most of them are not really monoclonal, but here the percentage of the same rearrangement is so high that you can decide very easy, this is a clone, and then make your decision. The patient has not only mycosis fungoides, which is a cutaneous T-cell lymphoma, but also the leukemic form, the Sézary syndrome, and this clone has been reproducible over at least 4 years. And another example you can see here. Here we did a wrong diagnosis. With a gene scan assay, we decided this is a clonal population that must be a cutaneous T-cell lymphoma, and reanalyzing this with the lymphotrack, you can clearly see this is not a clone. This is a sum of lots of small populations. So indeed, this is polyclonal. And of course, here, this is not longer mycosis fungoides. It's a parapsoriasis en plaque and a self-limiting disease which can be treated symptomatically. For me, that was the first time I learned this, how easy this is and how reproducible and how fast. And then our decision was we would like to use this test in our routine procedure. Another example, this is vice versa. You see from this 64 years old patient, a polyclonal pattern here of T-cell receptor gamma chain. And then you see here, maybe from a second biopsy, is this polyclonal or not? I think it's from the complete aspect, it should be polyclonal. And the question is there a clone included or not? And then in this lymphotrack presentation, you see here exactly the clone, the rearrangement, and the percentage. Everything is clear. And then you could go back to histology and find a typical T cells within the epidermis with this, the typical T cells showing this indented nuclei. So that was really helpful for us. And the second and third biopsy from the patient showed a growing clone from exactly the same rearrangement pattern. So in clinical outcome is really the reality. Okay, and we analyzed 52 cases of mycosis fungoides and 34 cases of parapsoriasis en plaque. And just to show how many polyclonal or clonal cases are included, and you see here, indeed, no clonality in 11%. Maybe this is an out-of-frame rearrangement, but you have to change diagnosis. And more clones detected in 10%, and in parapsoriasis, at least 12% of the cases transmigrates from parapsoriasis to peripheral T-cell lymphoma. They are then clonal and must be treated as initial phases of mycosis fungoides. So in my or interpreting this data, in my opinion, initial mycosis fungoides can be diagnosed much more earlier. And of course, you should always look for histological analysis and immunohistochemistry evaluation. But taking this 3 parts of the whole picture together, you can be very safe making the diagnosis of mycosis fungoides. And in the end, the decision is clonal or polyclonal. And indeed, the question, what is more dangerous, this part or this part? And you can make now your own decisions. Now we are in the end of the presentation. I'm very happy that you attended this webinar, and I'm waiting for some questions.